Thank you. Thank you very much for the kind introduction, and it's a real honor to be giving the grand round here today. It's such an impressive and amazing institution. I don't think I've ever seen such an enormous and special pediatric hospital. They must be very proud to work here. So, real pleasure to be part of this today, and to also be invited at the same time by the SADS Foundation, good friends and colleagues, and meeting new friends and colleagues by joining this exciting day, and the faculty dinner last night, and to thank the organization and to thank all the people behind it, including the patients and the families, who are what we're here about and what my talk will be about. So let's get on with it, because you've got about 50 minutes of me, so you probably want that over sooner than later. So I will be speaking, as I said, about sudden cardiac death in the young. These are my disclosures. And these are some of the documents I'll be referring to, just to go back to for clinical context. And this is going to be a relatively clinical talk, because I'd like this to be broadly appealing. And some of my colleagues will be saying, seen that slide before, but they'll just have to put up with it. So that's one from 2013 that first kicked off consensus statements and guidelines in this area, followed up in 2020 by the APHRS-HRS-led document on sudden death and decedents and their families, and the consensus statement on genetic testing, in which a critical part was around genomics and genetic testing in sudden death. And then more recently, the ESC guidelines, where we really enshrine genetic testing as an important part of prevention of sudden death, diagnosis of cause of sudden death, and for risk stratification as well, and including for the first time the sort of processes that you'll see me referring to today. And so when I refer to things as green as class 1 and yellow as class 2 and amber as 2A and amber as 2B, for example, those are sort of conglomerations of all these guidelines put together into something that makes sense for me and hopefully makes sense for you, because they are generally all heading in the same direction. So in terms of context, sudden cardiac death clearly is a very important cause of mortality or form of mortality, and is probably the most common single presentation of cardiovascular disease in the Western world. But it's also very important around the world, including certain areas where sudden death in the young is one of the most important causes of death amongst young males, say in Thailand and Southeast Asia. We know that in older age groups, such as this survey that covers the 1 to 64 age group in the UK, the majority of causes are ischemic, and non-ischemic causes identifiable at autopsy. But there is a slice there that are unexplained, which we'll delve into more as part of this talk goes, focuses on that. In terms of the overall epidemiology in the younger age group, 1 to 35, there are a number of different studies, and they're all different according to the nation, according to the methodology. Is it death certificate driven? Is it autopsy series driven? Is it using national statistics? And those have all got their faults. But you'll see the range here between 1 to 2.8 per 100,000 per annum, from autopsy through to quite comprehensive death certification studies in Denmark and Ireland. And I think, therefore, that top end figure is probably more reflective of what we're seeing in most Western populations. But also, if your population focuses on sports or training groups, you'll see the difference between the Veneto estimates for general population and sports training populations of about double the risk. And obviously, the US military seems to be quite a fearsome place to exist in terms of risk for sudden death for various reasons. If we then focus down a bit more on the 1 to 18-year age group, I think the group that have done the most work in this area, the Danish group led by Jacob Falk-Hansen, a good colleague of ours, you start to see a lower incidence rate as you get into that younger age group. More sudden unexpected deaths, of which the majority are sudden cardiac deaths in this particular setting. But with an age distribution that's intriguing, you've got that peak at the beginning coming off the infant group. So this is just after the infant group, from 1 and above. And then it gives this J shape starting to pick up again. So in fact, the age distribution shows this scoop and picking up in adolescence, up into adulthood, and of course then into the maybe what we think of as the less genetic causes. So if we think about the definitions that have been used, we can put them together as cases where there's been a sudden and unexpected and unexplained death. In somebody over the age of 1, we can call it SUD, sudden unexplained death, or SUD, sudden unexpected death syndrome. There are different ways of using the terminology, but I think that's what we've arrived at as being the most consistent. And if we then go into the infant group, so that's from birth through to 12 months, we see the shocking statistic of 27 per 100,000 live births, at least in the UK, and that's after all the protective measures that have gone in, back to sleep, all the measures that we think have helped to reduce SIDS. But nonetheless, we're still struck with this horrific figure. And in our consensus documents, we've therefore used SUDI, sudden unexplained death in infancy, with a negative pathological and toxicological assessment, and SIDS really to refer to where there's also been that additional forensic analysis that is really critical to excluding foul play in the setting of infant death. So, as we all know, if we're going to get to the bottom of it, the first step has to be an autopsy. And that's our first class 1 recommendation there. Coroner's or medical examiner's autopsy, retention of tissue suitable for DNA extraction if you do not know the cause or if you suspect a genetic cause, and expert cardiac pathology. Now, that middle one's critical because even if you do find that it's an explicable cause that's not genetic, if you've never taken the genetic sample, you've never actually allowed for the possibility, and you're never going to make the diagnosis on a genetic basis in the future. I think that's going to be increasingly important for us. So if we look at pathology, this is a macroscopic view of a section through the heart, the mid-ventricular level. This is asymmetric septal hypertrophy. But you can't just look at the macroscopic aspect of that. Could have so many different causes, from lysosomal storage disease through to sarcomeric disease. And this is the more the hallmark of sarcomeric disease, disarray and fibrosis can be present at certain sections of the normal heart. But if it's present more pervasively, then that's pathognomonic for hypertrophic cardiomyopathy in the setting of that hypertrophy. So that's the scar tissue with the whorls of pink-stained myocytes around it as well. Then there's arrhythmogenic right ventricular cardiomyopathy, another mid-ventricular section here from my colleague Mary Shepherd. And you'll see that fibroadipose infiltration from subepicardium through to endocardium. And that's visible again microscopically, and it's the fibrous tissue with the fatty tissue that's critical for this diagnosis. And there's an overlap with dilated cardiomyopathy, where cases that have had ventricular arrhythmias and presenting with dilated cardiomyopathy may as well be classed arrhythmogenic cardiomyopathy as a wider view of arrhythmogenic myopathic disease. We have dilatation of both the left of both ventricles or just the left ventricle alone. And often when you look at ARVC cases and see that right ventricular involvement, you actually look closely at the left side, you'll see it as well, even though it may not be present clinically in families. And this is the microscopic evidence of fibrosis disrupting myocyte structure and providing that substrate for arrhythmia. If we then start to look at population studies delving into this group, this is an example from Australia and New Zealand. We'll see that the mixture of phenotypes here, lots of different cardiomyopathies, adding up to a large proportion that are potentially inherited and genetic. Also aortic dissection in there as a cause, and premature coronary artery disease in the young that could have a familial basis as well in terms of FH. And there's this large group of unexplained cases, autopsy negative, 40% in this study. And in fact, if you look across most studies, depending on the settings, you'll see there is that slice of the pie that is unexpected or unexplained, the normal morphological heart. And that's ranging here from 17% to 43%, but I think most of us will say that in the 1 to 35 age group, if you go for a good autopsy series, that we're looking around 35–40% being unexplained. And therefore, if you have that SUDS death that goes through that process of negative pathological and toxicological assessment, many of you will be aware of some of this work in San Francisco, where a lot of suspected cardiac deaths turn out to be toxicological. But if you do that process, you can term it autopsy negative sudden death or sudden arrhythmic death syndrome, SADS, which is what we do. So you'll forgive me if I slip into the SADS terminology in this setting, if it doesn't quite sit with the way it's used in the SADS Foundation. Now, you will see expert pathology was mentioned in one of those Class 1 recommendations, and the reason for that is there's one particular study that my colleague Mary Shepherd did at St. George's at the Cry Center for Cardiac Pathology, a charitably funded research and clinical cardiopathology service for unexpected sudden death cases. They looked at 200 cases, of which a proportion, a majority, already had provisional diagnoses made by the referring pathologist from the coroner. Unfortunately, while the majority agreed with the expert assessment, there was still a large proportion that didn't. They tended to overdiagnose the ARVC. That's mainly by overassessing fatty infiltration without fibrosis as being the etiology, and underdiagnosing that that's actually part of the spectrum of the normal heart. And so if you look at this matrix over here, you'll see that the diagnoses of normal heart increased from 57 to 80, and the ARVC diagnoses dropped from under expert hands. The approaches then we then take into trying to understand further the etiology of the unexpected death is partly related to diagnosing the cause of death, but also identifying risk for others if there's a genetic etiology. And so one way is to assess the family, and the other way is to do post-mortem genetic testing, otherwise known as the molecular autopsy, coined by your SADS president here today. So what are the processes? If we've identified a cause that could be genetic, so it's hypertrophic cardiomyopathy, ARVC, etc., then that's immediate indication to go on and refer family for assessment. But you could also go ahead and do genetic testing, because you could immediately start looking for markers that are going to diagnose family members who may not as yet be exhibiting these predictive cascade testing. In this manner, we are actually therefore testing the genome, but we're going to test the genome in a very specific way, looking at the spectrum of genetic variation. So we're looking at genetic variation here in terms of allele frequency along the x-axis and the severity of the effect size of that allele on the y-axis. Some of you will be familiar with this graph. And we are looking at rare alleles, ultra-rare or novel alleles that are going to be causing disease with a high effect size. And they're going to be interrogated in a specific way. So we've done a particular study on postmortem gene testing cardiomyopathy, one of a few, but one of the early ones. And we've excluded variants that are challenging to evaluate, so those that are maybe more frequent, but may still have some impact on risk. Non-truncating variants in the largest gene in the genome, Titan, and synonymous variants not located at splice sites that are also separate. So this is what we then applied the American College of Medical Genetics classification to. For those of you who are familiar with it, sorry about teaching you to suck eggs, but this is in case others are not aware of it. There are different classes from class 1 to benign to pathogenic class 5, and we're really interested in class 4 and class 5 most of all, because that's immediately actionable as a diagnostic cause and for family members. And we use that in a framework for distinguishing pathogenicity. To interpret the variant effects, we look at the scientific literature. Does the gene where you found the variant actually associate with the disease you're looking for? Otherwise, it's not going to make that much sense, although we're starting to understand more about pleiotropy. Look at population databases. Is it very common? In which case, can it really be causing rare disease if it's that common? But is it also described in association with the disease or related diseases? And therefore, are the allelic data to support it there? Is it the correct functional effect, loss of function or gain of function? And can you segregated in a family with disease, or is it a de novo, not present in the parents, and therefore more likely by dint of how it's been generated sporadically to be disease-causing? And then there comes into it computational and predictive data and functional data that I think are increasingly going to be useful in informing our interpretation. And that's our spectrum of disease causation. So if we put that process through, and you'll see I'll apply it later, we apply it later in another set of postmortem genetic testing, we get a yield in this group of around of cardiomyopathy cases undergoing postmortem gene testing of around a third or so, just over a third, having pathogenic, likely pathogenic variants that are immediately useful in testing family members and confirm the cause of death. VUS's, variants of uncertain significance, that may be useful if we assess the family further and we can do more work to upgrade them. But still, some explanation there required for 46%, where we suspect that this is still a genetic cause based on the pathology. So we've done that bit. What about the unexplained ones, the SADS cases? So this is where we've had a normal autopsy, negative toxicology, and hopefully an expert pathologist has been available to give us that feedback. We can go on and do an arrhythmia-focused molecular autopsy, or we could do something a little bit more broad that may include cardiomyopathy genes as well, and that's maybe less recommended in the current guidelines. And again, we're going to focus on the rare variants that may be likely pathogenic or pathogenic, and so we're thinking here, because it's unexplained, predominantly we're looking at long QT, we're looking at Brugada syndrome, we're looking at potentially CPVT as our etiologies of interest. And so what are we expecting to see? Well, if we have long QT syndrome or CPVT, we're expecting quite high yields if we've already got the phenotype. In Brugada syndrome, relatively low yields, still more than the likelihood of just a variant of uncertain significance being present in the healthy population. So we've got a reasonable signal-to-noise ratio over there when looking at these potential important arrhythmia syndrome genes. In the historical smaller series that were done over the years, pioneered by Mike and colleagues, we found yields of these major genes involved in these major disorders of around a quarter in unexplained sudden death cases and SADS cases, with a background noise expected to be around 7%, at least in the European populations where most of these studies were done, giving a signal-to-noise ratio of around 3-fold just for these 4 genes. Now, I've just mentioned you may want to do more genes. Imagine that your yield is going to drop the more you include, and then your noise is going to increase the more you include. So that signal-to-noise ratio is going to be problematic. This was probably the first major use of next-generation sequencing in a population setting of unexpected sudden death, published in the New England Journal by Simsarian and colleagues, looking at a range of 490 deaths where they did actually have enough DNA to go on and do testing in the unexplained sudden death cases. So around half of those were, let's say it was 40% actually were unexplained, and around half of the 40% had enough DNA to do gene testing. They focused on 59 cardiac genes, mainly arrhythmia and cardiomyopathy genes, and went through this pipeline of genetic analysis, which back then was state of the art, but you may reflect on it now and think, well, maybe it wasn't quite as stringent as we would have liked to have done. For example, there were variants present in up to 1 in 1,000 of the general population, which is maybe not as stringent as we would have made it, using in silico tools, so computational tools to try and predict pathogenicity, and then coming up with around a 27% yield of clinically relevant gene variants, but not necessarily with the certainty that these are definitely disease-causing. So they had them in those major 4 genes, but you'll see the other contributions were from more minor cardiac arrhythmia genes, cardiomyopathy genes, and rare cardiomyopathy genes. So quite a broader spectrum of involvement. We went on to do something to follow that work up in around 300 cases from an international cohort looking at around 77 genes linked to cardiomyopathy and channelopathy, and combining it with our clinical data. We went through that same process as we'd done with the cardiomyopathy cohort, and we found about half the yield that the Australian and New Zealand team had found, around 13% yield of likely pathogenic variants. But still, with a large proportion of variants of uncertain significance that may actually contribute to improving that yield, but a lot of those were all related to cardiomyopathy rather than necessarily channelopathy. So still a challenge to understand in the setting of autopsy negative sudden death. We won't have time to talk about concealed cardiomyopathy, but that's something that can always come up in discussions later. The main molecular diagnosis was, interestingly, CPVT, RYR2 disease, a particularly pediatric disease. And indeed, this was more male affected and younger group and more exertional deaths. So it did actually pick out the phenotype where the mode of death and the presentation of death, sadly, was more akin to CPVT. And in fact, a large proportion of these cases have been to see a neurologist first for exertional seizures. I think many of you know as an entity yourselves, so I'm sure neurologists don't see it as an entity, but somehow they avoided ever getting an exercise test done before they died. We even did a burden analysis comparing cases to controls done through the same platform and the same panel, and really found that RYR2 was the only standout gene. There are other genes with some significant association, but when you're correcting for multiple testing with Bonferroni, it was only RYR2 that did so. So it's clearly an important player in unexplained sudden death. And I'm going to show you a little bit more about where we place that. Other work done by Mike at looking how to use genetic testing more effectively takes the trio approach of using the parents and the child to triangulate the results. So if you're able to demonstrate that this is a de novo variant, that you may find that that you may increase the likelihood that you have a pathogenic or likely pathogenic variant. So there are around half of these cases, just under half, had a positive result on molecular autopsy, of which the majority were VUSs, variants of uncertain significance. And by triangulating with the parents, they found that 3 of those were de novo, and that therefore then increased by half, the pathogenic calling of the variants to increase the yield and immediately provide the diagnosis and give reassurance to parents about future children as well, expecting, as long as we've excluded potential issues around mosaicism, which can occasionally complicate matters. There was also another follow-up study in a larger group from New York, looking at sudden expected death in childhood, 124 trios with exome sequencing, giving around a 9% yield here, which was a little bit disappointing from that point of view in terms of how low it was. There was a prominence of de novo variants from these trio studies, and there was a real important yield from calcium channel, L-type calcium channel loss of function variants, which is something that bears further scrutiny. And the fact that the yield didn't really bring us a lot more. RYR2 was there as well. There was only one epilepsy variant present there. So I think the main hope of the group to try and pick up more on the expected death in epilepsy as a potential cause. So we've been through the process of how a molecular autopsy may give a diagnosis and then be able to be applied in family members. You then have to actually assess the family as well, because most of those results are still going to be negative and there still could be genetic disease there. And if there's been no autopsy undertaken, you're just starting blindly. And unfortunately, that's probably the majority of scenarios that most have to deal with. I think we're relatively, in quotes, lucky in the UK, and that there is that most cases of unexpected out-of-hospital sudden death will have autopsy done, if not all. And you do have to assess then the family history and the context, because clearly if there are other sudden deaths in the family history, that's going to raise the bar of there being genetic disease or lower the bar of genetic disease. And the circumstance of death may also give you clues. For example, sudden arousal, auditory arousal, and long QT2 subtype of long QT syndrome has been a pointer in some of our families. So the evaluation is focused on first-degree relatives, particularly obligate carriers in the pedigree, so individuals who by dint of their position in a family, must be affected because one relative on one side and one on another is affected. And of course, symptomatic relatives need to be prioritized, those who already have symptoms. And the initial valuation, including family history and examination, but also using the resting ECGs with high right ventricular leads that I'll show you in a moment, exercise ECG and echo. And I would say these are, in the ESC guidelines, these are class 1 now as the standard. You may also then do additional tests of 24-hour ECG and cardiac MRI based on physician preference. The 24-hour Holter very rarely gives any yield. If those are all negative and you've got a high index of suspicion for Brugada syndrome, in our approach, we do offer patients, once you've been through that whole exclusion process, a sodium channel blocker challenge. Not got a high index of suspicion, you may still wish to consider that and even may consider an epinephrine test, but we've discouraged that, particularly in the European guidelines. We wouldn't use it in long QT syndrome diagnosis in all comers, and we would only think of using it in CDD. So this is an example of a class 1C challenge. I presume you'll be using procainamide, most of you here. We typically use ajmaline, which is a more potent and selective sodium channel blocker that has a very short half-life. So we can do a test in 5 minutes, and an hour later, the patient's gone. Not spending too much time and it hooked up to the ECG monitor. So this is an example of a positive challenge after 3 minutes of infusion. The brother of the ECG I showed you earlier for Brugada syndrome, a type 1 pattern. And we also use the high right ventricular leads. So these are in V1 and V2, traditionally placed in the fourth intercostal space, but moved the second and the third. We've lost one of the ones, seems to have dropped there, but second and third intercostal spaces. My Roman numerals went wrong there. And that will give you a potentially greater view of the right ventricular outflow tract and its electrical activation of the type 1 pattern in patients with underlying Brugada syndrome. And the same happens with ajmaline challenge in this example. This is the fourth intercostal space, where you'll see the baseline suspicious but not diagnostic in V2, but clearly diagnostic of a type 1 Brugada pattern in the second intercostal space. Quite a dramatic one, and I think the more dramatic, the more likely. And we're going to talk more about ajmaline testing briefly in my talk about Brugada later. If we look at our series of SADS families, this was reported in 2018, about 300 families. Brugada syndrome was our biggest diagnosis based on offering that in a systematic way. Once we know the autopsy is negative, once we know the molecular autopsy is negative if it's available, and once we know that the family member has been through all the other tests without signs of phenotype in every individual member in the family. There has to be an exclusion process because, as you'll see later today, it's not a terribly specific test, sodium channel blocking test challenge. If we combine systematically molecular autopsy with family evaluation, this was a subset of our last SADS molecular autopsy study that I referred you to, where we had 80 out of 300 families undergoing both. You'll see we increased the yield significantly from just family evaluation alone by including molecular autopsy by around 50%. So we're getting around a 40% yield of using family evaluation alongside genomic testing and antecedents in order to arrive at a clinical diagnosis that impacts on family management and prevention. And this is data coming from 760 cases, 407 families. This is in review, I think due to be published soon. Just over 400 family members, 400 families, excuse me, and 424 molecular autopsies. There was a bit of an overlap in a minority between the two. Unfortunately, not all happen. They are happening prospectively these days in the UK because of national pathways. But this is our historical cohort. And you'll see diagnoses. Now, there's very small letters. Blue is Brugada. The brown, reddish hue, I'm red-green color deficient, so forgive me when I reinterpret colors for your for your benefit. And then you've got the sort of the more purpley hue CPVT and then yellow cardiomyopathy there. Have to change those colors one day. More of a gray on this screen. Anyway, you'll see throughout the age groups along the x-axis, Brugada is there as a proportion. This isn't absolute numbers, this is a proportion. And this is where we've been able to do family testing out of the 760. So it's not that all of them have been able to have family testing. It's only 407 that had family testing, for example. But in terms of the yield from this cohort, there's this consistent yield even in the younger age groups of Brugada syndrome. I'll be talking about that later today. This is the yield for long QT. You'll see that there's certainly a peak in the younger age group, but there's still evidence of it proportionally in older age groups. So it's still potentially useful to thinking about molecular testing. But CPVT, you can see it's all really evident in the younger age groups, as one may expect. Females have more of a diagnostic yield than males, and that's most notable with long QT gene testing and molecular autopsy. These are sort of Bayesian predictive analyses based on those data. So we've got family evaluation there with the age group again. You'll see there's a relatively consistent yield, although slightly downward over time from doing family evaluation. So it's still useful to do it in older age groups. The molecular autopsy yield is always better in the younger age groups. And this is good to see because our original data didn't necessarily support that, but we actually started to see that once we got more cases. And in terms of the yield of long QT, you'll see from family evaluation, it really peaks in the early age group, but in molecular autopsy, it's a bit more useful in the older age groups to still pick out that older people are dying from long QT syndrome suddenly and unexpectedly, without necessarily having a prior family history for it either. And then CPVT, you'll see family history, family evaluation is nowhere near as effective as a molecular autopsy at diagnosing the underlying cause, where genomics are picking up probably because there's more sporadic disease there. If your autopsy is ambiguous, this is some old data from our group just to point out that it's still likely to be channelopathic. So these are examples where there's a floppy mitral valve may have been given as the cause, where right ventricular fatty infiltrations, I mentioned to you, might have been given as the cause, unexplained fibrosis, and you'll see we made diagnoses there, mainly not of cardiomyopathy, but of Brugada, long QT, and CPVT, and these were coexistent factors, may have contributed, may not have contributed to risk, but it meant that those where we had not families with ambiguous and non-specific autopsies, we still had a channelopathic yield of around 46%. So if you don't have a clear cause of death, treat it as autopsy negative sudden death SADS and investigate it that way. And of course, if the diagnosis is made, we have great guidelines these days and consensus around how to manage patients, or great in terms of offering if you want to improve them. And with regard to follow-up, it's really important that children of decedents are followed up, that children in families with disease are followed up because of age-related penetrance with specific conditions, particularly in the setting of Brugada syndrome. Adults, really grown adults that are negative phenotypically in this setting and genotypically negative in families, I think can deserve to be discharged and reassured. Very little sign of ongoing risk in those families. If we move now on to infant sudden death, the underlying risk in infant sudden death has been proposed to have be a triple whammy, effectively, of genetic predisposition with an environmental risk during this vulnerable period, particularly in the first 4 months of life, particularly the 2 to 4 month period where sadly infant deaths, particularly young males, are at their greatest. Monogenetic risk has been posited as a cause, those affecting the autonomic system, the immune system, and the metabolic system. We had an exome sequencing study, a control burden sequencing study that Mike, Dave Tester, myself, and colleagues studied. And this is an analysis of those pathways, genes in those pathways, comparing cases to controls. and there was no significant difference with these numbers, at least, of finding rare variants in these particular pathways as being causative. One thing we did spot that we published was a particular musculoskeletal channelopathy, SCN4A, associated, which gain of function and loss of function can cause disease that can cause respiratory paralysis. About 1 to 2% of our cases had functionally affected variants in SCN4A, and there was a slight burden in variant findings on significance levels between the case and control analysis. We focus on the cardiac system. We've done a review of case series. It's very small. I can see Al shaking his head there, but if you add it all together, it suggests there must be a yield around 14%. So this is getting close to the yield in older cases of variants in cardiac genes underlying sudden infant death. So we went on and did something similar, looking at cardiac genes, increasing the size of our cohort, over 400 unrelated Caucasian cases compared to just under 1,000 European controls. We focused down using PCA on the European ancestry cases where we had a better number of controls to compare to at that time. We did compare the cases overall, and there were no differences between the European and non-European cases. There's a predominance in male sex, and the 2 to 4 month age was where the peak of deaths occurred, as expected, sadly. We did a cardiac gene-specific analysis, very similar to what we'd done previously in molecular autopsy, looking at very rare or novel non-synonymous variants, again, looking at rare variants. We used EXAC at the time because it hadn't quite shifted to NOMAD at that point. You can see the yields of these ultra-rare variants is extremely high. Across the cases, around half carried variants in cardiac genes. Those that we deem to be potentially informative are there, and we'll talk about what actually turned out to be pathogenic or likely pathogenic in a moment. But we look at potentially informative variants. Those are called loss of function or missense variants within 90 genes that had abnormal in vitro function data. And because there were prior data on the channelopathy genes, we allowed the channelopathy genes to slip through as potentially informative if they were rare. Clearly, they could still be VOS. If we looked at the potentially informative variants, they were much lower in the under 4 month group. So it seems that maybe the under 4 month group cardiac risk may be less likely to be present than the over 4 month group. Maybe there are more generic factors about early neonatal period than the later post 4 month period. And if we then look at our likely pathogenic yield, it's only 4%, much less impressive yield than we would have hoped for something to give us traction for helping families very quickly. And if we looked at the major channelopathy genes, this is just in the ultra-rare variants, the statistical burden test only found a significance if we group them all together for these ultra-rare variants that aren't pathogenic, likely pathogenic, with no significant differences overall. There are trends there. So clearly there's a signal there, but it's a signal that's going to be really challenging to interpret if we roll this out to all sudden infant death molecular autopsies. Nonetheless, if there has been a SUDI death, the recommendations are to collect the suitable information around the death and test and genetically extractable material. Consider autopsies being undertaken by an expert cardiac pathologist, but there aren't many pediatric expert cardiac pathologists in the world. They're probably less than that. And it may be useful or can be useful to an arrhythmia syndrome panel. And if you find something, then it's class 1 to go and look at the family, likely pathogenic. And if there's family history that's supportive of other sudden deaths or genetic heart disease in the family, then it's a class 2A to go on and test the family. And it may be useful to assess family members as they continue for follow-up to other children in that context as well, if you already know there's prior risk. Evaluating everybody may be considered, but just no data for it at all. In fact, the data around family evaluation are very lacking. So in conclusion, optimal evaluation of a young sudden death means ensuring expert pathology. That means retaining the whole heart and also retaining DNA or tissue suitable for DNA extraction. That ambiguous result means SADS or autopsy negative unless otherwise proven. Yield is greatest in females or greater in females, greater in childhood and adulthood for LQTS, in childhood for CVVT, and you need clinical evaluation. If you do it, then you'll find Brugada syndrome being present across all age groups. If you don't do it, then you won't find it. That's a question one can ask them. The optimal evaluation of the family means assessing first-degree relatives, single patients, obligate carriers I've mentioned, using the high right ventricular leads for class 1 channel blocker testing, and it's effective across all age groups. Behr autopsy is increasing and getting cheaper through the high throughput methods. While we can find just over 10% yield in SADS, you can see if you target it in the lower age groups, you're going to get better yields, and we're getting better and better, I think, for assessing variance. The work from ClinGen is going to really change that, and the investigators behind it. Remember, CPVT is going to be important, and remind our neurology colleagues that those children with exertional syncope is not an exertional seizure. But we still have to address those limitations to the US's, but I think we're going to get there in time. Combining with clinical evaluation is very important. Don't rely on the gene test alone. Don't rely on evaluation alone. Try and do both if you can. And that can therefore inform trio studies. Just talked about SIDS and that we see this much lower yield, and there are roles for non-cardiac genes in there as well that we need to think about and include in the long term. The role for family evaluation is really uncertain, and I think we just have to use red flags like family history as being those. Often families need it for their psychological reassurance. That's important also. And I think one thing that's come through the whole talk, from my perspective at least, is that you always need to interpret your genetic results very, very carefully. Thank you for your attention.
Contribution to sudden death. Is it something that in Mary's hands and you guys' hands you can see on autopsy, or is it?
Yeah, you can see that there are a small number of cases, and it has to be relatively gross to be able to diagnose it clearly at autopsy, because there'll be elongated leaflets, etc., that are going to be present in quite a large proportion of people. But if you see the myxomatous changes and the evidence of morphological change in the valve itself, and you can see the function if you section appropriately, then yes, it can be diagnosed, and Mary does diagnose those in a small proportion. But those mitral valve prolapse in those series were just a little bit of floppiness, and that was also that was often being indicated by referring pathologists as the likely cause as well. And of course, there's also potentially scar associated with the.
It wouldn't be much fun if we weren't a little bit provocative, right?
Go on, Andrew, do your work.
So, excellent talk, Elijah. So, two questions. One is, our friend Jacob Feld-Hansen has been big on this idea of unrecognized toxicology. And in fact, our processes are very focused on a foul play kind of approach to toxicology as opposed to a cause of death.
Sorry, what approach?
A foul play sort of investigation,
okay, yeah.
because most coronial systems are actually out of justice, not out of health, from the standpoint of safety and security. So I wonder if you would comment about that. And the second thing is, you're going to talk about Brugada later, but I think we would all acknowledge in general, Brugada is not usually a Mendelian condition. And so then it makes me think that the compelling statement around Ajmaline response is really confounded by a signal to noise ratio and a lot of false positives.
Okay. So, well, we're going to talk about it this afternoon, but we'll touch on the first. So let's do the first one, toxicology. Yeah, I think it's mandatory in the setting. I think we'll all agree on that. Obviously, there's interpretation of it. There are some challenges, particularly post-mortem, and how drugs redistribute and change in different settings, whether it's in urine or in eye samples. Struggling for the word there with my jet lag, apologies. And blood samples, particularly when there's been thrombus formation. So sometimes your levels are not going to be accurate, and you toxicologists to interpret them for you. So clearly in overdose, that's going to give a cause, but there'll also be where there's a therapeutic level of a toxin or a toxic agent, whether it's a medication that causes sodium channel blocking or QT prolongation, or whether it's a drug overuse. How is that impacted on an underlying risk? And in general, if the levels aren't high enough, but then I wouldn't necessarily exclude the case and the family from evaluation, because it could be that was revealing the underlying risk, particularly with QT prolonging drugs. In terms of using Ajmaline, well, I mean, our yield there was 22% of relatives, 28% of cases. And I'm going to show you later today that if you go with if you go into a healthy control with no family history for 3 generations of sudden death and a normal ECG, at a 3% yield of a type 1 pattern under Ajmaline. Now, we will be publishing them in future what the different levels of type 1 pattern may be. There could be more likely to be a Brugada than not a true Brugada. But that's 3% yield versus 28%, sorry. And so there is still a 25% gap there. And I don't think we can just wish that away as being false positives. I think, and I don't necessarily think that we're thinking about Brugada syndrome in the right way. We call it a syndrome because it's got some ECG features on it. That's not a real syndrome. That's just a description of an ECG abnormality that, in the end, is a susceptibility to risk. And so I think what we are demonstrating with Ajmaline is that there's a familial susceptibility to risk that is mostly polygenic, oligogenic in some families, sometimes strictly monogenic, depending on the variant. So we do have to treat it in a very complex and personalized way. But if we don't ask the question, we're not going to give the answer. But for me, I think we have to address the genomics first, then the Ajmaline test, and then eliminate the Ajmaline test.
Any other questions?
But another easy question for me.
Elijah, thanks a lot. That was fantastic. I wonder what your thoughts on are. What do we need to do to actually move the needle to uptake of the molecular autopsy? So one of the things I'm struck by is I think we did the first molecular autopsy in 1999. So we have 25-year history on it, and yet there's the comments that are out there, well, the yield of SIDS genetic testing is quote unquote only 10%. And let's spot it at 10%. You showed 14%, but let's say it's 10%. The yield in a teenager is quote unquote only 25%. And that's a significant yield. And yet in other fields like neurodevelopmental delays, our neurodevelopmental delay colleagues do Fragile X genetic testing all the time. Standard of care. The yield, I think, is 1%. And yet that's standard, and yet in our world, it seems like we still have an uptake problem. I mean, it's not, I wonder what kind of progress are we really making when sudden death family I saw just this week, no molecular autopsy, no DNA-friendly tissue archived. It's still happening, and I'm not sure. We've got the guidelines out there. They're pretty clear, and it doesn't seem like we're making progress, or maybe I'm just annoyed by this week's scenario, but I really don't think we're making as much progress as what the evidence base would suggest we should be doing.
Yeah, I think we're struggling with the, and I'm sorry, I don't want to offend anybody here with the US fact that states do whatever they wish to, counties do whatever they wish to. There's no federal process for this. I can give you a quick description of what's happening in the UK now. We've got an integrated national service for genomics now. We got genetic testing and unexpected sudden death onto the directory for testing. The lead for the genomics unit said, we're not getting good uptake on this, why not? We said, well, because of this. We only have one specialist center in the UK that's doing this systematically, and that's only for a proportion. So the NHS is about equal delivery at the point of care for everyone. And so we developed a pathway that is now rolling out nationally, where all coronial referrals of unexpected sudden deaths, where there's a suspected genetic etiology that's flagged up by the pathologist, goes into the system, flagged up to the Inherited Heart Disease Service, and flagged up to the genomic laboratory hubs that partners put the centralized. So it's a national health service. It's a centralized process, and we're bridging it to the Department of Justice on a national level. And there are just so many challenges to doing that in the US compared to doing it in somewhere like the UK. It's a smaller nation, but it's a national service. So I think the only way I personally think of delivering that is to try and get a federal process going, to get recognition of it on a national level. And I think the people who are going to do that are the patients and the families more than the doctors. They have a lot more political power than doctors ever do. Doctors are ignored because we're seen as an interest group, but patients and families are voters.
Elijah, thank you for that wonderful talk. And I'd like to ask Mike the question, because that's such important work. Is it education? Is it marketing? Could it be tied, with the question you just asked, could it be tied to other legislation in terms of prevention that, yes, we're going to advocate for CPR AED education, but you have to know that in situations where families have this, there's an opportunity to do better. And I don't know the answer to the question, but I'm wondering if it could be tied to something like that.
I think it comes back to what Andrew said, Dr. Cron, in the sense of medical examiners' offices are under the Department of Justice. So once they've ruled out foul play, they've satisfied their mandate. And there are many medical examiners' offices are on shoestring budgets. And so while I think even their community has struggled. So National Association of Medical Examiners, they know these guidelines. They see them. They're trying to see if they can add some teeth to it, but they're trying to add teeth to an office that is understaffed, under-resourced, and their mandate is rule out bad behavior. And until there's the resources given that says, now that you've ruled out bad behavior, how about seeking the answer? And I think that's where we need to make some progress. And I think maybe it's the partner. It's going to happen at a community level. I mean, there's a lot of things. We don't need a national health system per se to increase uptake. I mean, the neurodevelopment community didn't need a national health system in the United States where Fragile X testing is done on every patient almost with mental delays and so forth in search of explanation for low yield. So I think it's not the structure. I think it's to me, it's that corner community, medical examiner community, they just are under-resourced.
I think, but the point is that because there was a national genomics service, we'll take the cost of the test. It's not up to the insurers to decide. It's not up to the medical examiners to pay for it. It's not up to the family to pay for it. It's up to the National Health Service to pay for it. The National Health Service puts up its hand for it.
But that comes to will and a desire. So at Mayo, we've offered free secondary autopsy. So to the medical examiner community, a cardiac autopsy coupled with a postmortem autopsy, because you really, like what you've done, you have to combine the phenotype even after death with the genomics data. And so just getting DNA on a sample where that death was evaluated by a medical examiner, and in his or her real day job, they are an ophthalmologist, because some of the medical examiners are coroners. They're not necessarily cardiac pathologists. In fact, most are not cardiac pathologists. So we've offered free cardiac pathology overread of the tissue combined with postmortem, and even offering free. The response of the medical examiner community remains suboptimal. So there's resources, and even when you give free, I think there's sort of will and just having an intense dissatisfaction that you're telling this family, we don't know why your child died, but we're going to keep looking. And I remain puzzled by why the movement to getting this test truly standard of care is really 10 years slow. We've known it should be standard of care for at least a decade now. It's not a research-based assay. And yet in the last 10 years of where the evidence is irrefutable to me, I think the transition to standard of care practice is incredibly slow.
I think part of that, is really addressing the coroner's education understanding. So when I started doing this 25 years ago, most of the coroners were not interested, that were zealots. Now, by far, the majority are interested. More than a few are the zealots that really push it, and it's only a small number that are dismissive or disinterested, because the old have been replaced with the new, and the new are better educated about it because of the ongoing pressures from families in particular, and from family charities. Cardiac risk in the young in the UK, SADS UK as well, but also therefore, SADS Foundation has got a big role to play. But the problem is you've got a massive country with so many. There are 100 senior coroners in the UK. I can't imagine how many medical examiners and coroners there are in the US.
Well, this is an audience that also has general pediatrics trainees. And so I'll ask one last question that is relevant to general pediatrics trainees. As you've noted, in the United States, our medical examiner and coroner system is incredibly distributed. And each individual practitioner may or may not see much sudden unexplained death. So they'll often call the local pediatrician and say, you're going to see this family. What do you want me to do? You gave us some data about long QT syndrome throughout the lifespan. Is there an age at which you say to coroners and medical examiners, I think the yield here is too low to continue to pursue? Or how do you answer that if you're a general pediatrician and you get a call from a local coroner in a small office that says, this parent that you're going to see their kids is this age, should I continue down this pathway?
Yeah, no, I think it's going to be there lifelong. It's just we know that these disorders are or variably expressed in completely penetrant disorders, and variably expressed in families and individuals in those families. So there's never an age to say no, but if someone's 85 and never had a symptom and doesn't want to be tested, I wouldn't be chasing them. I'd just say avoid these drugs just in case. And if you've got a gene test, it's probably our most robust arrhythmia syndrome to do predictive gene testing on with assuredness that somebody who's negative is not going to be at significantly elevated. I think gene testing there is going to be very useful to cut out a lot of the clinical testing. Maybe still do an ECG on some relatives, particularly if it's a relatively weak variant, functionally speaking. But yeah, I don't discriminate on age at all from that point of view, or sex.
Greg, this is an area, if I could add, that for the general pediatric community, we could use tremendous help, because I think we're doing a terrible job in the first degree relative evaluations of the sudden death family members. Because we do the drill, nothing's found, we leave them trapped in this mindset that we didn't find anything, but the second shoe is going to drop eventually kind of mindset. So let's look at you again and again and again. And we haven't communicated that the evidence from Arthur Wilde and others is pretty clear that the silver lining is if you do this drill that we're supposed to do, and we find nothing in the first degree relatives, and then let's say we do it again in 1 year, 2 years, 3 years, and we find nothing, second tragedy basically never ever happens. And so the silver lining is finding nothing is actually great news. And at some point we have to free these families to be that it's not just there and we can't find it. Maybe it's just not there because there is nothing there. And I think we leave these families kind of psychologically trapped in a mindset that tragedy is going to strike again soon, instead of giving them this more encouraging perspective of, we did the drill, so far so good, great, maybe we'll do it again. And I've seen programs where they're evaluating these first degree relatives. It's like a cottage industry out there. They're running some drill every 6 months. And I think we have to figure out a way to communicate what's the minimum evaluation. The guidelines have said that, but we haven't quite communicated how often. Do we really need to do this same drill every single year? I don't think we do. Can we start stretching it out? Can these family members ultimately get dismissed and be free rather than under the notion of it's kind of the boogeyman's out there, just we didn't catch him or her this time?
I think it's important that we therefore do evaluation the first time the family comes properly. So I've got one example historically, just is a family that was assessed elsewhere. The mother and parent and father were tested with sodium channel blocker, standard testing, no high right ventricular leads at the time, and nothing was found. Second daughter then died suddenly, 10 years later. We got the family sent to us and we retested them with high leads, and the mother had a barn door type 1 pattern, Ashmolean testing in the high leads. So I think we have to do the right testing, whether it's procainamide or Ashmolean, that's up for debate, but we have to do the right testing. But then once you've done it and it's negative, there's nothing more to do for a grown adult. We discharge them straight away. I only keep them on if they've got that ectopic burden of 500 VEs and their Holter. Let's check that again in a few years' time. That sort of suspicion level. But otherwise, they need to be discharged. The decedents, the children of the decedent, though, does need to be rechecked, but it doesn't need to be done at intervals other than for what you're looking for. So if there's no sign of long QT, you're not going to repeat testing for long QT. You're looking for something that's age penetrant. Is it going to be incompletely expressed cardiomyopathy, or is it going to be Brugada syndrome? You focus on those, and then those are only going to become relevant at different stages in life, say during puberty and early adolescence, not when they're 2 and then test them again at 3 or 4 or 5. And we don't do sodium channel blocker testing in children until, unless there's a major anxiety about their ECG and symptoms. The real no-no. Because their age penetrance for Brugada is very critical.
Thank you, everyone, for such great questions and great discussion. And thank you, Dr. Behr. I learned a lot.